Hello, my name is Nasser Ssenyange, and I'm investigating a critical and timely issue at the intersection of medicine, public health, and equity: disparities in the prescription of GLP-1 receptor agonists across racial and ethnic groups in the United States. The drive to pursue this research stems from having read Medical Apartheid by Harriet Washington and a personal experience with my mother. After having read Medical Apartheid and learning about the history of the inhumane experiments done on African Americans, and seeing that the disparities that exist today are not by chance but are a byproduct of systematic racism, my resolve to go into medicine to become a doctor was fortified. A few months after reading the book, my mother received a diagnosis from the doctor that she was pre-diabetic for type 2 diabetes. I was shocked, and not even an hour later, I saw an ad for Ozempic on the TV. Coupled with the knowledge I had gained from reading Medical Apartheid, I say to myself, I bet the people who need this medication the most do not receive it as they should. Now, GLP-1 agonists, whether they are semaglutide or liraglutide, have revolutionized the management of type 2 diabetes, and more recently obesity. Some popular examples include Ozempic and Victoza. These medications are very impactful, but they are also high cost, and it is important to note that access to these medications is not equal. With their popularity increasing, a rising concern is whether those who need GLP-1 agonists for type 2 diabetes management face greater competition from those who seek to use them for weight loss. Recent research studies have shown that Black and Hispanic patients are significantly less likely to be prescribed GLP-1 agonists compared to white patients, even after controlling for clinical factors like BMI, HbA1c, insurance, or income status. These disparities are deeply concerning because type 2 diabetes and obesity is disproportionately higher in the communities, and also due to these communities already being on the negative side of health disparities. So my research asks, what factors drive the racial disparities in GLP-1 agonist prescriptions? More specifically, I want to find out whether it is provider bias, systemic inequities, or patient trust, or such things as income, that drive these disparities to continue to exist. To answer these questions, I'm conducting a retrospective analysis using EHRs, which is electronic health data, from large healthcare systems, enhanced data, and also interviewing several physicians. I'm using this multivariable approach to control for socioeconomic status and provider type, and also to isolate the impact of race and ethnicity. This research isn't just about numbers, it's about understanding why these disparities persist. Are providers making assumptions about patient adherence or affordability, or are structural barriers like insurance coverage and out-of-pocket costs playing the biggest role? By identifying where the gap lies, whether it's at the patient level, provider level, or policy level, we can begin to address it. The goal of this research is to inform interventions like bias training, policy reform, or targeted outreach that can improve prescribing equity and ultimately health outcomes for marginalized communities. GLP-1 agonists represent a breakthrough in chronic disease management, but if they only reach certain populations, we risk widening the very gap that we aim to close. I believe research like this can guide us toward a more equitable healthcare system, one prescription at a time. Thank you.